Successful use of an EZ-Blocker for lung isolation and visualization of sutures during minimally invasive robotic tracheobronchoplasty in a patient with difficult airway. The true incidence of tracheobronchomalacia is unknown. It has been identified in 1%, 2-4.5% of patients undergoing bronchoscopy and reported in 13% of patients with respiratory symptoms. In patients with symptomatic severe tracheobronchomalacia, a stent trial is performed. Placement of bronchial stents prevents airway narrowing during expiration and, thus, helps to determine if the patient's symptoms are, in fact, due to tracheobronchomalacia. If symptoms improve or resolve, then patients are referred for tracheobronchoplasty. Standard anesthetic management for tracheobronchoplasty, open or robotic, is placement of a double-lumen endotracheal tube. The disadvantages of using a DLT for tracheobronchoplasty include the need for modification of the tube, the need for endotracheal tube retraction into the distal trachea, and ventilation temporarily suspended during suturing of mesh to the left mainstem bronchus. An alternative anesthetic approach is use of the EZ-Blocker, which has several advantages. In this issue of the JCVA, the authors reported a 63-year-old woman presented with progressive respiratory decline resulting in shortness of breath with exertion and an oxygen requirement of 2-3 min. She reported frequent hospitalizations and treatment with antibiotics and steroids. Comorbidities included hypertension, insulin-dependent diabetes, gastroesophageal reflux, asthma, and obstructive sleep apnea. Pulmonary function testing was consistent with a mild restrictive defect with forced expiratory volume in 1 second at 70% and carbon monoxide diffusing capacity at 69%. CT of the trachea demonstrated a stable 3.7 cm anterior superior mediastinal order with no airway compression in molastic airways consistent with crescent-type tracheobronchomalacia. Dynamic bronchoscopy confirmed tracheobronchomalacia that extended to the distal trachea and bilateral mainstem bronchi. Measurements revealed greater than 90% distal tracheal narrowing, with 80% right mainstem, 80% bronchus intermedius, and 80% to 90% left mainstem. The initial plan to deploy a silicone-wise stent via rigid bronchoscopy was unsuccessful due to the extreme anterior airway. Preoperative airway examination was consistent with the Malampati airway classification of 3, short thyromental distance, reduced neck range of motion, and limited mouth opening. The airway management was notable for difficult mask ventilation requiring a two-handed technique with 2 providers. After multiple unsuccessful attempts by attending anesthesiologists with direct and video laryngoscopy, Macintosh 3, 4, Miller 2, Glidescope 4 with a Cormac-Lehane grade 4 view obtained on all attempts, the airway was secured with a size 5 laryngeal mask airway. An endotracheal tube was placed over an exchange catheter, allowing for satisfactory stent deployment using a flexible bronchoscope. With stents in place, her symptoms improved. Therefore, the stents were removed 2 weeks later, and she was scheduled for robotic tracheobronchoplasty. Intubation history, the team decided against attempting placement of a double-lumen endotracheal tube. Airway management was performed using a sleep fiber optic intubation with an 8.5 single-lumen endotracheal tube placed and the tip secured 5 cm above the carina. A bronchial blocker, EZ-Blocker, 7.5 FR with hollow center in each channel then was passed along with the fiber optic scope through the tube and correctly positioned so that each cuff could occlude the bilateral mainstem bronchi. The right bronchial cuff was inflated, resulting in 1 lung ventilation of the left lung. After right thoracoscopic insufflation and right lung deflation, The surgeon dissected the mediastinal pleura and exposed the posterior membrane of the mid-distal trachea, carina, right and left mainstem bronchi and bronchus intermedius. A polypropylene mesh then was sutured to the posterior membrane under FFB visualization by the anesthesia team, which allowed for confirmation of extraluminal sutures. Right mainstem bronchus suturing was achieved by the intermittent deflation of the right bronchial cuff and the suspension of ventilation at the time of suturing, followed by reinflation and ventilation. At the conclusion of the surgery, the EZ-Blocker was removed, a bronchoscopy with aspiration of secretions and inspection of the airway was performed, and the patient was brought to the intensive care unit intubated. She was extubated on postoperative day 1 and discharged home on postoperative day 8, with no postoperative complications. 3 months after surgery, her dyspnea and cough had resolved, with repeat CT demonstrating no residual tracheobronchoplasty. In conclusion, the EZ-Blocker through a single-lumen tube should be considered for similar cases, particularly for patients with a difficult or stenotic airway in whom a double-lumen tube placement is not possible.